Olá a todos, mais um evento aqui do A.D.F.S, um prazer ter todos vocês aqui conosco. Hoje com uma presença ilustre, uma aula que é um marco para cirurgia de pé e tornozelo, cirurgia vascular aqui no Brasil, uma aula com o Dr. Gang Lee, um entusiasta e desenvolvedor da técnica do TTT, do Transversal Tibial Transporte. Dr. Gang Lee nos deu a honra de falar diretamente da China. Ele vai se apresentar, um currículo impecável, vai compartilhar conosco a sua experiência com essa técnica cirúrgica que tem sido um divisor de águas no tratamento do pé diabético, com resultados de salvamento superiores a 85%. Dr. Lee, thank you very much. It's a pleasure. Please, we are here for you.
Okay, so good evening, everyone. I'm Gang Li from China. I'm presenting from Shenzhen in the northwest of China. No, we are in the evening, so you are in Brazil, and we are quite far away, 12 hours ahead of you. So I'm very pleased to tell you a new technique today about TTT surgery and its underlying mechanisms. So a little bit introduction about myself. I have received medical training in China and also surgical training in Navarre Department Orthopedic Surgeries in the University of Oxford, UK. That's like a long time ago, as you can see, when I was a young man there. And I did my surgical training in the same department in University of Oxford, in the orthopedic surgery department. So consequently, I was working in the UK, Queen's University, Belfast, as a senior lecturer and a reader. And then I moved to the Department of Orthopedic and Traumatology in Chinese University, Hong Kong, since 2008. And last year, I moved back to China, Shenzhen, the Chinese Academy of Science, Shenzhen Institutes of Advanced Technology. I'm leading a center for regenerative medicine in this new center. So as you can see, this is all the established research directions in my team. I'm mainly working on stem cells and destruction histogenesis novel applications. Today, I'm going to introduce you about destruction histogenesis and to see the new applications in the treatment of diabetic foot ulcers. You may recall this classic series about tension stress principles in orthopedics, which was defined by Russian doctor Elijov. His theory is that mechanical stimulation, particularly the tension stretch, is the key factors in restoring and maintaining tissue regeneration. So destruction histogenesis refers to apply attractions to the bone here, as illustrated here, and that lead to local response, such as all the genes controls bone formation like BMPs and inflammation-related genes, all upregulated by mechanical stretch. And in the same time, there are a lot of mechanotransduction signal genes also being upregulated and leading to angiogenesis and bone remodeling. In the same time, this mechanical tension stretch also triggers systemic response, such as stem cell mobilization, cells migrate to circulation, and also a lot of factors such as cytokines, growth factors released from the injured bone, tissues into circulation, and that will promote bone remodeling. So this destruction histogenesis or destruction histogenesis technique is widely available in orthopedic surgeries, particularly for deformity corrections and for limb lengthening. As I show you, this is one case we did in China. This is a man suffered from A.D.F.S, achondrodysplasia. It's a congenital disease. He was very short. It's only 1.2 meters height. And we use as the destruction histogenesis surgery, we successfully managed to give him another 40 centimeters increase of his height. As you can see, he gained 40 centimeters after 3 surgeries. So this is nothing special in orthopedics. However, in the classic textbook written by Elijolov, he described a surgery called tibial cortex transverse transport, as illustrated in his book, as shown here. In this surgery, what he did is he split up a cortical bone from a tibia and transversely elongate this cortical bone. And by doing so, he make the bone widening. But in the same time, when he do angiograph exam, he demonstrated that by pulling this piece of cortex transversely, it successfully promoted all the blood vessels proliferation and ingrowth into from the bone marrow cavities to the peripheral of the limb. And this is transverse lengthening. When we do longitudinal lengthening, as we do limb lengthening, and we also showed that there's a lot of blood vessels formed in the newly formed bone. And imagine this is our newly formed bone. You can see the blood vessels coming from the intramedullary nail and connect across the newly formed bone gap. When we have a close look of this piece of bone, we do section, and we found that there are a lot of new blood vessels in the regenerating tissue, bone tissues here. So this is a very clear evidence suggests when we stretch the bone, regardless transversely or longitudinally, it will promote blood vessels growth. And however, the rate of lengthening has to be slow. You know, in clinical practice in orthopedics, we all know slow lengthening. Usually we use a rate of 1 millimeter a day in 2 or 4 steps. So that means very, very slow tractions will lead to angiogenesis. This tibial transverse cortex surgery was first practiced by a doctor in northeast of China. This is him, Dr. Chu, used to be my old friend. He was an orthopedic surgeon, but he worked in northeast of China where we have some vascular conditions called TAO. This is TAO patients. It's some kind of inflammation in the arteries, small arteries in the distal limb for unknown region. We don't know precisely what is the cause of this. Sometimes the cold weather, heavy drinking, or smoking may cause this, but there's no efficient treatment for the TAO conditions. Therefore, Dr. Chu, that's like 24 years ago, trying this tibial cortex transverse surgery using a device he designed himself. And this is the patient's angiograph, TAO patients before the surgery, and this is during the surgery, and you can see there are more new vessels grow around the surgery site and certainly to the distal side. And the clinical symptom of the patients significantly improved after the TTT surgery. So he published this in Chinese. That's like 24 years ago. And it was in the record. But it didn't cause a lot of attention at the time until recently. Diabetic foot ulcers become one of the challenging conditions. We know we are in an aging society, and a lot of people, particularly in the elderly people, suffer from type 2 diabetes. The estimation is about 8% of the population in the next few years will suffer from type 2 diabetes. There's a lot of people getting diabetes. And 4% of the diabetic patients eventually will develop complications, severe kidney failure, eye disease, and in orthopedic is diabetic foot ulcers. So those are diabetic foot ulcers. We refers to the foot infections, ulcers, and in deep tissue damage, usually accompanied by peripheral vascular vascular and peripheral nerve lesions. Current treatment for this nasty condition is offloading, of course. I think some of you are orthopedics and some of you are vascular surgeons. You all know, and then the surgical debridement, and also need medications for the patients. However, for the severe diabetic foot ulcers like this, half of them will not respond to the standard treatment and therefore resulted in gangrene and eventually lead to limb amputation. So this is the data I got from the New England Journal of Medicine. They have a review articles about diabetic foot ulcers management. Patients with diabetic ulcers and amputation, their likelihood of dies 5 years mortality rate is about half, is about 50%. So that's a very bad news for the diabetic foot ulcer patients. And therefore we need looking for a new management method to, at least to salvage the limb or the feet. So that's come to the TTT surgery. Since this is about 10 years ago, some doctors in China thought about Dr. Chu's publication, which is for the treatment of TAO, and they thought that may work, for diabetic foot ulcer as well. So they start trying. This is a very early cases I show you. It's by no means perfect, but this is just an experimental case. Patients suffer from very severe diabetic foot, otherwise will amputate. So this is early days. You can see the cut is very big, and big, bone windows, larger cortical bone windows, like 10 centimeter long times 2 centimeter wide. And the external fixator is very bulky at the time. You can see here, it's very bulky. And therefore, sometimes it causes complications, such as skin necrosis, as shown here, or you can see this tibial fracture. And this is obviously a rare case, but it does happen. But majority of the patients after the TTT surgery, they same heal the wound, otherwise will be amputated. So this is a very, very promising, despite we have complications. So this is Dr. Hua Qikai from Guangxi province. He's working in the medical university in Guangxi province of China. He and myself, we came together, we decided we have to modify the surgery to make it less invasive. So this is the modified surgical procedure. As you can see from these photos, we make the cut very small. Instead of 10 centimeters, the skin cut is only 3 to 4 centimeters long. And the cortical window, we reduce it in half, like 5 centimeters times 1.5 centimeter wide. And we this is how we do the corticotomy, and then this is how the screws were inserted, and then we use a smaller external fixator. Of course, it's free-sampled external fixator. So by changing this method, we significantly reduced the complications and also enhanced the therapy efficiency. And the limb salvage rate increased nearly 90%. So this is the first paper Dr. Hua published in clinical orthopedic related research. This is nearly 5 years ago now. You can check this paper, which is free download on the internet. So Dr. Hua, in his hospital, he did, in this case, he did about 200 patients. He using tibial cortex transverse surgery, and he has two groups. One is a control, means the patients didn't receive the surgery, but only standard treatment like offloading and debridement. The other group, patients, they also receive debridement, offloading, plus TTT surgery. And the severity of the two groups, diabetic ulcer patients, are similar. They're all very severe diabetic ulcers, Wagner's 3 or above classification. And this is the table from the paper. I just quickly lead you through. In the TTT treatment group, you can see there are about 136 patients. In the control group, 137 patients. They are similar. And ulcer healed by 6 months. So in the TTT surgery group, you can see 126 patients ulcer healed. So nearly 93 patients healed within 6 months. In the control group, however, is only 41 patients. Only 56 patients, sorry. It's 41% patients healed by standard treatment. Amputations, in the treatment TTT group, is only 4 patients out of 136 amputated, so less than 3%. And in the control group, 31 patients out of 137 patients amputated, so it's 23% amputation. Very interestingly is the recurrent rate of the ulcers. You all know diabetic foot is very nasty conditions. Even you manage to heal the ulcer may come back very quickly. So they follow the patients in 2 years' time. Within the 2 years, they see the ulcer recurrent rate. In the TTT treatment group, as again, only less than 3% patients have ulcers come back. However, in the control group, it's about 17% of the patients ulcer come back. So this is obviously a first clinical studies demonstrated the TTT surgery does work for severe diabetic foot ulcers limb salvage and also promote healing. So this is a few cases I borrowed from Dr. Hua from his publications. And as you can see, this is not too severe. This is Wagner's 2 skin ulcers. Patients received TTT surgery and dressing change regularly. And within 2 months, ulcers nearly healed completely. By 3 months, completely healed. This is another Wagner's 3 cases. It's very much severe case. And one toe already be amputated here. And this is TTT surgery, as you can see. And And this is TTT surgery, as you can see here. And this is after the ulcers completely healed and the patients can walk. And this is another case. Patients suffer from Wagner's 4 ulcers. You can see the gangrene is already there, and this one toe is already been amputated. This is after debridement. You can see this toe is all being removed. You all know in this case, it's very difficult to heal if you don't do anything, and may lead to amputation. And this patient received TTT surgery, and this is after 2 months. And you can see the ulcers fresh up, and the gangrene formation. Not the gangrene, I mean, you can see the granulation tissues fresh up. And this is 3 months, this is 4 months after. Completely healed, and patients can bear weight on this foot. And this is another Wagner's 4 case, again, very nasty. And after TTT surgery, you can see the ulcers eventually healed, and the patients back to normal life. Okay, so encouraged by all these cases, and we carried out some multi-center trials in China. A lot of surgeons in China all of a sudden become very interested in this. And we come together and have a consensus and also draft a clinical guidelines for the treatment of diabetic foot ulcers using the so-called TTT surgery. So this is the first clinical guideline published by Chinese Association of Orthopedic Surgeons in the General Orthopedic Translation in the year 2020. This is free download online. If you are interested, please check this paper. And we have a lot of details put into that paper and tell you how to choose the patients. So very briefly, I'll lead you through the indications for the TTT surgery. First of all, the TTT surgery is not for everyone, not for every diabetic foot ulcer patients. It's only for severe diabetic foot ulcer patients. We are in China, a lot of doctors using Wagner's classification, which is a classic classification for diabetic foot ulcers. But somebody also use Texas classification or others, but it more or less similar. So type 3 Wagner's class 3 diabetic foot refers to deep tissue infections, usually have osteomyelitis and very nasty, and it's very difficult to treat. So the first indication for the TTT surgery is severe diabetic foot ulcers, which Wagner 3 and above. And patients may receive standard treatment like offloading, dressing changes, even VSD dressing changes, and standard medication for more than 2 months. It didn't work, no obvious improvement. So those patients may be the case. We can do it. And also, if some hospitals, they can do vascular bypass surgery, or patients cannot do it or refuse to do it, then obviously those are the suitable case. Some hospital, if you have the facility to do vascular bypass surgery, you can try that first. If it didn't work, then you can try the TTT surgery as well. And the second most important issues for patients who is suitable to TTT surgery, we must check their vascular conditions. We have to make sure at least one anterior and posterior tibial artery branch reach below the ankle joint level. If below the ankle joint, then the likelihood of failure is high. Okay, so how to check that? You can do DSA, you can do laser Doppler check, And so that's a very standard way to measure the blood supply to the feet. And some hospitals also use ABI or artery pressures, but they are not very accurate. So it's not that essential. I think the essential thing you need to remember is, first of all, severe diabetic. Tried other standard treatment didn't work. And secondly, at least one branch of muscle, small arteries reach below the knee ankle, the ankle joint level, then those are the patients suitable. And of course, patients has to be generally well. They can tolerate the surgeries if they have other complications like heart conditions, kidney conditions. So you must make sure they can tolerate the surgery and talk to physicians first. So who cannot do this surgery? First of all, patients cannot cooperate, like mental ill or very very bad conditions, other organ conditions wrong, then don't do it. Secondly, if there's no artery branches reach beyond the ankle joint, then try not do it because the failure chance is high. Okay, let's move to the tools for the surgery. I mean, this is the kit I invented in China. This is like 80 years ago. We have an invention granted in China, and this is the device, the B-Fix. I think they are promoting this in Brazil now. And this is this device already been approved by CE marketing. We have already sold this device in many countries in Europe. I will show you a few cases. So this is the product is already registered and in China and in Europe. And we have like several generations. This is the first generation, second generation. I think now in Brazil is the third generation. It's much smaller, and we already sold in most of the provinces in China, over 20 countries in the world, including Italy, Germany, Spain, Denmark, UK, Switzerland, and I think Mexico as well. Brazil is starting, Australia is using it, and Malaysia and Singapore. It's all started. Okay. So how to do this surgery by minimal invasive means? So we also published a technical paper. It's already published in the General Orthopedic Translation. You can download this free online. Myself is the leading author, so I described in great details how to produce this surgery. I have a small video. Let me see whether or not it will work. We'll try. Can you see the video?
Yeah, it's not the
Can you
video,
see the
but
video
no,
working?
it's not running the video. It's just the picture.
It's okay. Yeah, this is the illustration how to do the surgery.
Okay, we can see the picture, but it's not running the video.
Can you see? You cannot see?
Yeah, can you hear me?
Yes.
Yes, we can see the picture, but it's not running the video.
Oh, you cannot see the video?
No, just the picture, not the video.
It's okay. That's okay. Don't worry about it. I will go next. I show you how to do this without the video. I mean, this is a picture illustration. I mean, you can read my paper. It's all in the paper. Okay, you can take a photo and download the paper. You can read it
Okay,
yourself.
fine.
So basically, we have a plate, guiding plate like this. Position it on the tibia, medial aspect of the tibia, about 5 centimeters below the tibial tuberosity, right in the middle line, as shown here. And then we use a K-wire to secure the Jilin guide. This is exactly the piece of bone we're going to cut. This is a metal drilling guide. And then using the external fixators as a reference to make sure this 2K wire positioned in the center. And I show here, and then we do a small skin cut as illustrated here. Very small cut. It's about 1.5 centimeter cut. So there's 1 to 4 or 6 cuts like this. And then we're using this drilling gig, which is supplied with the kit. So you put the jig through the skin and using this plate, metal plate as a guide. All you need to do is just draw the holes one by one, okay, and moving around the guiding plate, okay. And then what you do, imagine you have already draw all the holes here, and then you put the fixator on, and then using small ostome or tweezel to connect all the multiple holes together. And by doing that, you basically you did the corticotomy. And sometimes you can check under X-ray flow count like this to make sure you cut the bone properly. And where you can move the bone up and down the piece of cortex bone, and then the surgery is finished. That's it. And then this is how you suture. You can see the cut is small, really small, and in contrast to the bigger cut in the past. Now we are using this smaller cut. And so we don't have any skin necrosis anymore when we're using these new surgical procedures. And the video, actually, I can forward that video to you through Caro and our local supply, and you can see the video yourself. So those are the cases using our new method. You can see, again, using our new method is very efficient to promote the healing of diabetic ulcers. This is within 6 weeks. You know, this nasty ulcers healed completely within 6 weeks. And of course, we have other conditions like TAO also work. And this is some of the surgeries we performed. And I just want to illustrate you how we do the surgery. You know, it's very small cut like this. And then after the surgery, you can do the debridement. This is before the surgery. This is after debridement. We would remove this toe, and that's it. That's what it looked like. And the first case in Europe was done by Dr. Iroko Brancos from Milan. I remember that's during the COVID pandemic period, 2022, May. I remember I was online to teach him how to do it. This is the first case. So this year, actually, in March this year, I went to Milan to see Dr. Branco. He's working in the Medicare hospital in Milan, and they are using new generations. You can see he is using very small cut. This is Dr. Branco. And he did more than 25 cases or 30 cases in Milan. 90% of them successful. He was very happy to use this surgical technique. And this is the last year I was in Mexico City, teach Mexican orthopedic surgeons in their orthopedic congress last year. And this is the workshop we did there. As you can see, they are very happy. I think they started in Mexico City already. So this year, actually, I went to Spain, actually. In Spain, there is a city called Murcia, which is close to Madrid, actually. They have a University Murcia Medical School. Dr. Cesar Scrando. He was orthopedic surgeon, and he was very skillful. And he already done 5 or 6 cases in Spain, very successful. And the Spanish newspaper also reports. And we have also ran TTT cadaver workshop in Murcia this year. Actually, about 100 people attended. It's a very, very good one. Okay, I will move to the second part of my talk, which is about possible mechanisms, how it works. First of all, why we have to cut the bone. When we cut the cortical bone, we have an instant release of marrow cavity pressure. So we call it decompress the marrow cavity pressures. And that will promote angiogenesis in the distal limb. Here is one example. This is the patients before the surgery. We did a DSA for to check the vascular conditions. And you can see these patients have a very faint tibial anterior arteries at the ankle joint level, very faint. And we did a TTT surgery on these patients, and you can see this is after 2 weeks after the surgery. We did another DSA to check the vascular condition, and all of a sudden you can see there's a lot of more blood supplies in the distal, in the anterior arteries and posterior tibial arteries below the ankle joint. So this patient healed pretty well. This is before the surgery, amputate the tools, and then this is after the surgery, healed pretty well. And this is also a paper published in Nature Metabolism. This is a few years ago, 2 or 3 years ago. They're talking about the new network of transcortical capillaries as the mainstay for blood circulations in the lung bones. So this paper described in the cortical bone, there are a lot of tiny blood vessels, as illustrated here in the experimental animal cortical bone. You can see in the cortex. This is the cortical bone. This is the marrow cavity. You can see a lot of these tiny vessels they are talking about. Can transport the blood through the periosteum, through the cortex to the marrow cavity here. And this is illustration. So, and this gives us the anatomical base why we have to open the cortical bone here. If we do that, we will stimulate the transcortical capillary network, and eventually will promote angiogenesis to the distal limb. So this is the anatomical foundations of the TTT surgery. Okay, so in order to study these mechanisms in greater depths, we developed animal models in Hong Kong. So this is the illustration of how we do the TTT surgery in the rat. So we mimic exactly the same conditions as we do in human, and then we just downsize the TTT parameters, and we apply this in diabetic rat, as you see here. And using diabetic rat, we demonstrated how TTT surgery works. So this is the rat have a skin defect. Without TTT surgery, you can see within 2 weeks, the wound cannot heal. And this, the rat, we did a surgery, but we didn't do any manipulation of the cortical bone. We do the cut, we put the fixator on. It has some effect, but it's not very, very significant. And this is group, we did TTT surgery. We do the corticotomy, also we manipulate the piece of bone. How we manipulate, when we do the surgery, we wait for a few days, 3 days, the piece of cortical bone up 1 millimeter a day for 5 days, and then we push it down 1 millimeter a day for another 5 days. So it's totally 10 days procedures, and you can see the wound is significantly speed up, the healing process. They have statistical differences. And also the skin quality, we measure the blood flow to the distal limb. Only in the TTT group, you can see significant enhancement of the blood flow. I mean, this is the laser Doppler image compared to the control groups. The healing quality of the wound is much more better. In the shame group, you can see it's all scar healing. And in the fixator groups, also scar mailing. But in the TTT group, you can see normal skins, which epiderm and subcutaneous tissues also nearly normal. So, and also we checked the blood vessel conditions by using micro CT, infusion. And you can see only the TTT group, there's significant enhancement of angiogenesis in the wounded area. It's statistically different. So this paper is also published in Bond Joint Research, and this is in the year 2022, which you can download free online. Okay. And other possible mechanisms is very interesting. We thought, systemic factors release is a possible mechanisms. I tell you, this is a very interesting story. First, we encountered a farmer like this. He has two huge diabetic foot ulcers on the two heels. One heel is very severe. They have osteomyelitis already here. And this patient, he cannot afford to do TTT surgery on both limbs at the same time. So we did TTT surgery on one side first, okay, this side, much severe. And to our surprise, so within 3 months after this TTT surgery on one leg, both ulcers healed. Both ulcers healed. So this is very interesting. And then we see another case of patients. He again have a very severe subcutaneous infections. You can see a lot of infections here. After debridement, we couldn't do surgery on this limb. It's all infected. And which patient's consent, we did the surgery on his contralateral leg, which is normal. And to our surprise, when we do the surgery on the contralateral leg, this wound healed very rapidly. So this is something telling us must be some factors released by the TTT surgery to promote diabetic healing. So this is another patient I did personally myself. Again, this old patient, he suffered from chronic ulcers for many years. These ulcers always came back and very difficult to heal. And the skin condition wasn't great in this leg, so we decided to try the contralateral leg. He's happy to allow us to try. And when we do this contralateral leg, we can see this wound very quickly fresh up. Within 6 weeks, healed completely. Okay, so why is this? So we have to go back to animals to see. We have a hypothesis that the TTT surgery may mobilize stem cells into circulation. And to prove it, we use GFP labeled cells from the GFP rats. All the cells are green. And we culture these green cells, and then we use a normal SD rat. We create wound on his feet, and then we apply TTT surgery. At the same time, we inject the labeled MSCs to see where it goes. And this is a long story, and I don't have time to go through very deeply, but what I want to show you here, the data is, when we do DDT surgery, we can see a lot of more green cells moved to the diabetic wound area, as illustrated here. This is all the cell countings in the diabetic wound area. Only in the TTT group, you can see the mobilization of stem cells is very rapid to the wound area. And also we demonstrated this movement is due to the TTT surgeries released factors, promoted factor release into the serum. The factors we identified is CICR4, is SDF1 actually, it's a stem cell mobilizing factors. And so if we block the SDF1 by using a drug, then the TTT surgery, is not working well in these animals. So this paper is in the process of getting published, and we also identified TTT surgery actually promote stem cell mobilization by releasing SDF1 from the wounded bone area, and SDF1 through all these signaling pathways can promote stem cell migration. So I think I have enough for the mechanisms here, and just give you a very quick summaries, conclusions. I hope that I lead you through the TTT surgery, which is a very simple, cost-effective technique to manage severe diabetic foot ulcers. But before you do it, please read our clinical guidelines and also follow the step-by-step guide. In the publications, I published the technical papers, how to perform minimal invasive TTT surgery. And then please use our specially designed external fixators like this. And cortical, for the corticotomy, you must use the guide plate, as illustrated here, and also using the drilling gate, as illustrated here, for reproducible and successful TTT surgery. Okay, so finally, I want to acknowledge my team. There's teamwork. I have a lot of talented young surgeons and scientists work with me, and we continue to improve the TTT surgeries and also understand underlying mechanisms. So I will stop here, and I will be glad to answer questions if you have any. Thank you very much for your attention.
Dr. Lee, thank you. It's amazing, amazing work. I am very impressed with this, and I have some questions for you.
Sure.
First of all, I can't wait to have you here in Brazil with us to learn with you and experiment your experience. So, some questions here. How long time do we need to observe clinical better for the patients?
Oh, yes. Usually we do the surgeries and after the corticotomy, we wait for 3 days. We start the protocols of so-called lengthening. We do 1 millimeter per day lengthening, using the frame. Just turn the screws for 5 days. You pull it up, gradually the piece of mount. 5 days, and then usually we teach the patients or their caretakers to do it. Just turning the nuts. 1 turn in the morning and 1 turn, 2 turns actually in the morning and 2 turns in the evening for 5 days, and then after that we push it back.
Okay.
Do the opposite way to compress the cortical bone back to the original position. So that's about 10 days. Well, plus 3 days waiting, that's 2 weeks. This is one up and down. We call it 1 circle. So this is 1 circle is about 2 weeks. In most of the cases, in China at least, within the 2 weeks, we see positive response already. Basically, the positive response is like this. the second day after surgery, about more than half of patients will tell you they have an instant relief of pain. And
Right.
also they have an instant feeling of warm feeling of their feet. So that means they have increased blood supply, decreased the microcavity pressure, and allows the existing vessels open up and pressure release, and also reduce the edema conditions. So if the patients tell you the pain is better and feel very warm on their feet, that's a good sign. That's at least half, of the patients worked already next day after surgery. And when you do this, up and down for 2 weeks, about 80% of patients, you can see the wound. Of course, during this process, you have to do the dressing changes as we do regularly. Every 3 days, you change the dressing. And during the dressing changes, you can see the wound fresh up. Granulation tissues become pink color, and the color is obvious different. I mean, before the surgery, they are very pink, very pale, and not enough blood supply. And then after the surgery, 3 or 4 days after, you can see they pink up, like a pink color and obvious, fresh up color. And then if that happens, you don't need to do second circle. One circle is enough. All you need, because the bone healing, the cortical bone healing, take a long time. Even you put the cortical bone back to the original position, it will take more than half a year to heal completely. So during that process, somehow there's some factors still released from the bone remodeling side. And also they continuously release the bone marrow pressure. So this is the reason why I insist we need to do corticotomy. If you don't cut the cortical bone, there will be no long-lasting effect. That's why we see the patients after 2 years, they still benefit from the TTT surgery. In China, there's some doctors promoting another simple procedures. They just put a plate underneath the periosteum, and by expanding the periosteum, and some cases also work, but the long-lasting effect is not as good as TTT surgery. Okay, so
Okay.
so usually one circle will work, but some patients one circle it didn't not work that well, so some doctors can do second circle. You can push it back and then do it again. One more circle. That's about another 2 weeks. So maximum 2 circle. It
Circle.
didn't work. It didn't work after 2 circle.
Okay.
80% will work after one circle. And after one circle, you wait for another 2 weeks. If the wound start, closing up, you do the regular dressing change, and then you can remove the fixator.
Okay.
About 6 weeks after the surgery.
Okay. It was
Yeah.
another question. How long we keep the fixator in the tibia? Okay.
Yeah,
So when
usually 6 weeks. Six
okay,
weeks or maximum 2 months is enough. Yeah.
okay. This time 6 for 8 weeks after the end of the translation.
Yeah.
Okay.
Yes, that's right. After the surgery, 6 months after the surgery.
Okay.
Yeah, the
Uh,
translation only take about 10
10
days.
days. Okay.
One
Okay.
cycle.
About
And you,
the wound care, do you have any special care with the wound, like negative pressure therapy or any special band-aids or just the regular saline dressing?
I mean, for most of the patients, we don't have any special dressing. Just use ordinary dressing change. We use very mild antiseptic. Don't use alcohol. Don't use iodine, because that will hurt the granulation
Okay.
tissue.
Okay.
And never use hydrogen peroxidase. You only use hydrogen peroxidase for the debridement procedure, and after that, never. And some doctors also tried VSD, vacuum dressing. It helps a little bit, but it's not essential. You don't have to, because that's quite expensive. It costs more for the
Okay.
patients. Because so if the patients can afford, yes, VSD will help a little, but it's not fundamentally needed. Okay.
Great. Great.
Yeah.
Okay.
Yeah.
And you were very clear about the indications and no indications of the procedure.
Yeah.
Just ulcers Wagner 3 or above. But
Yeah.
in Wagner 2 ulcers that do not respond to regular treatment, do you think it's possible to use the treatment, the TTT
Yeah.
treatment? Okay.
Sure. I think yes, if the patient did not respond to standard debridement or dressing changes, or some of the patient tried vascular bypass, it didn't work, then
Okay.
you can try TTT. Yeah.
Great, great. Do you put the device, the sternofixation at the same time of the debridation or amputation, or do you do this in another surgery?
In China, we do the same time. Most of the
Same
time, we
time.
do the TTT surgery, which is clean first, and then
Okay,
after that, we do the debridement.
fine.
Same, under the same anesthesia. We don't need to
Same.
do second procedure. Yeah,
Okay.
usually we do that. But
And
sometimes the doctor prefer to amputate the tools, something first, and then wait for a couple of weeks, or even 1 week after, then they can do TPT surgery. It's up to them. I mean, I think it's unnecessary. You can do it same time. Yeah.
fine. After you take off the sternofixation, do you use any brace or any cast at the leg?
Yes, yes, yes. That's also help. We put in a plastic
That's great.
brace.
Okay.
Patients can buy that. I mean, China is very easy and it's very cheap.
Okay.
You can buy it
Okay.
online, and they can wear a special shoes as well for offloading, and allow them to bear weight. They can stand up,
Okay.
but use a special shoes, cushions to protect the ulcer site. Okay, don't have a direct weight bearing on the ulcer side, but they can bear weight for sure.
Okay.
Encourage them to stand up at least half hour in the morning, half hour in the afternoon, and move a little bit. That will promote more angiogenesis actually for the distal limb. Yeah.
Great, great. And for the final question, for venous ulcer, do you have an experience or see some changing in venous ulcer or just in diabetic foot and artery disease?
Yes, we have diabetic foot. I think we have a lot of experience, and also TAO, our vascular conditions, and for chronic, um, venous ulcers, it may also work. We
Okay,
have a few colleagues tried, and even we have one case report for lymphedema also help a lot.
okay,
Um, and for pressure sore, the patients have a pressure sore like a paralyzed patients. One doctors in China tried the same procedure in the iliac crest. It helped the pressure sore on the back heals. Um, but it's not common. But I think the principles applies. If the stem cell mobilize into circulation, they will move to the wound area, regardless in the feet or in the back or whatever.
okay,
That will work. In principle, I think you don't necessarily have to do it on the tibia, but you can do it in your crust. But tibia obviously is obvious. It's relatively easier because it's very easy to do the corticotomy in the tibia because it's very soft, little soft tissue coverage
yeah,
there.
yeah.
Yeah.
Okay, thank you one more time. It was an honor, a pleasure, and congratulations for your work. It's very inspiring for us. Thank you very much.
Thank you so much. Yeah, thank you. And I will be available. I mean, if anybody have questions, they feel free to email me And I will pass the video to the girl called Carol. She is the local distributor for the diabetes
Oh, yeah.
for the fixators. And Carol should have the video, and he can pass it to anybody who are
Okay.
interested to see it. Yeah.
Okay. Thank you one
Yeah.
more time. Have a great night. Thank you.
Thank you very much, Rafael, and I hope to see you in person sometime. Okay.
It will be a pleasure. Thank you.
Bye, everyone. I wish you all the best.